Greetings to Dr. Rickman and Dr. Dickesman. We will now present exercise 5, antibacterial agents. And here are the group 3 members. Moving on to the case, AB, a 4-year-old child diagnosed with bronchial asthma and acute lymphocytic leukemia, status post-chemotherapy with vincristine, doxorubicin, and L-asparaginase, presents to the ER complaining of difficulty breathing, accompanied by a 4-day history of remittent fever, reductive cough, nasal congestion, post-tussive vomiting, decreased appetite, and fair sleep. In the past medical history, patient has history of controlled bronchial asthma and acute lymphocytic leukemia. Upon physical examination, patient has a weight of 16 kg and a blood pressure of 80/90 millimeters of mercury. The heart rate is 130 beats per minute and the respiratory rate is 45 breaths per minute with intercostal and subcostal retractions, wheezes, and coarse rales heard on both lung fields. The temperature is elevated at 39 degrees Celsius and oxygen saturation at room temperature is 93%. The patient appears awake but weak-looking, with nasal discharge and nasal flaring. Additionally, poor skin turgor and capillary refill time of more than 3 seconds are noted. The laboratory results indicate an absolute neutrophil count of 800, hemoglobin level of 140 gram per dl, and hematocrit of 43%. The procalcitonin level is elevated at 3 ng per ml, and additionally, the chest X-ray reveals pneumonia in the right lower lobe. Upon admission, patient AB received hydration with D5-LRS and oxygen inhalation via nasal cannula at 3 IPM. The following medication were administered: paracetamol 160 mg intravenously every 4 hours, salbutamol nebulization every 4 hours, phenylephrine 5 mg plus chlorpheniramine 1 mg in 5 ml syrup administered at a dosage of 2.5 ml orally twice daily for 3 days, and Montelukast 4 mg tablet orally once daily. And for antimicrobial therapy, ceftazidime 800 mg intravenously every 8 hours, amikacin 80 mg intravenously every 8 hours, and trimethoprim sulfamethoxazole 400 mg 80 mg in 5 millimeters of syrup administered at a dosage of 2.5 twice a day.
Now we move forward to the pathophysiology of pediatric pneumonia. Pediatric pneumonia is an inflammatory response to proliferation of microbial pathogens at the alveolar level. And this may be due to exposure to pathogen, whether be it through inhalation, hematogenous, aspiration, or direct exposure of susceptible host and or virulent pathogen. And this will lead to infection and proliferation of pathogen in lower respiratory tract or parenchyma, thereby causing pneumonia. The risk factors include immunization status, immune compromise, secondhand smoke, air pollution, length of stay for past hospitalizations, recent antibiotics, mechanical ventilation, neonates, immunocompromised patients, underlying lung disease such as ciliary dysfunction, cystic fibrosis, and bronchiectasis. Because of this exposure of the susceptible host to pathogen, the body will elicit a local inflammatory response and systemic inflammatory response. So, for the local inflammatory response, neutrophils are recruited to site of infection, either lobar or interstitial pattern depending on pathogen, by epithelial cytokine release. This will lead to irritation of contiguous structures and or referred pain, leading to abdominal pain. The local inflammatory response will also lead to the accumulation of plasma exudates from capillary leakage at sites of inflammation, cell debris, serous fluid, bacteria, and fibrin, leading to irritation of airways and failure of ciliary clearance to keep up with fluid buildup, thereby causing cough, crackles, and decreased breath sounds. So, accumulation of the said contents will also lead to fluid buildup in spaces between alveoli, and an interstitial pattern, which will show interstitial opacity on chest X-ray. It will also lead to fluid buildup in alveoli, which will reveal lobar consolidation on chest X-ray. And lastly, it will lead to decreased efficiency of gas exchange, wherein there is an increased diffusion distance in interstitial and decreased surface area in lobar, leading to hypoxemia. As for the systemic inflammatory response, there will be cytokine release, such as tumor necrosis factor and interleukin 1, leading to increased respiratory drive, causing tachypnea and respiratory accessory muscle use, such as chest indrawing, paradoxical breathing, muscle retractions. The cytokine release will also lead to the disruption of hypothalamic thermoregulation. It is also important to note that additional findings in pediatric pneumonia may include nausea, otitis, and headache. So, viral pathogens are most common in children less than 2 years, and bacterial pathogens are most common in children more than 2 years. For interstitial pattern, the suspect would be Mycoplasma pneumoniae, influenza A and B, and parainfluenza. For lobar pattern, the suspect would be Streptococcus pneumoniae, Haemophilus influenzae, Moraxella, and Staphylococcus aureus.
Moving on to the pharmacodynamics, we have the first drug, vincristine, which is an anti-cancer chemotherapeutic drug. It works by interfering with growth of cancer cells, inhibiting microtubule formation, thus disrupting mitosis and causing cell death. Its adverse effects include peripheral neuropathy, constipation, hair loss, and temporary loss of menstrual period. Some adverse effects can include neurotoxicity, bone marrow suppression, and GI issues. It is contraindicated in patients with demyelinating form of Charcot-Marie tooth or people who have hypersensitivity to the drug. For teratogenic risk, it is categorized as FDA category D. It is not recommended in breastfeeding moms. For the next drug, doxorubicin is an anthracycline chemotherapeutic drug. It works by intercalating with DNA and inhibiting topoisomerase 2 enzyme, thereby disrupting DNA replication and RNA synthesis, leading to cell death. Its adverse effect includes nausea, vomiting, hair loss, bone marrow suppression, and severe effects can lead to cardiotoxicity, myelosuppression, and mucositis. It is contraindicated in patients with severe myocardial insufficiency, severe hepatic impairment, and it is known and patients who are known to hypersensitivity to doxorubicin. For teratogenic risk, it is categorized FDA category D, and again, this drug is not recommended for breastfeeding moms. Next is L-asparaginase. L-asparaginase is an enzyme used as a component of chemotherapeutic treatment. It works by depleting levels of asparagine, an amino acid essential for protein synthesis in certain cancer cells, leading to their death. So, the common adverse effects include hypersensitivity reaction, pancreatitis, liver dysfunction, and coagulopathy. If severe adverse effects, it can include anaphylaxis, thrombosis, central nervous system toxicity. It is contraindicated in patients with history of hypersensitivity to L-asparaginase. Its teratogenic risks are not known, and it is also not recommended to the women who are breastfeeding. Moving on to paracetamol, it is an analgesic and an antipyretic. Its mechanism is unknown, but it is a weak COX inhibitor. The adverse effects include hepatotoxicity in overdose, hepatotoxicity more likely with chronic alcohol consumption, which induces P450 enzymes. It is contraindicated in patients with severe hepatic impairment or people who have known previous hypersensitivity to paracetamol. The teratogenic risk for this drug is FDA category B, and paracetamol is considered compatible with breastfeeding when used in therapeutic doses. Next drug is salbutamol. It's a short-acting beta-2 adrenergic agonist. It works by stimulating beta-2 adrenergic receptors in the smooth muscles of the airways, leading to bronchodilation. Some common adverse effects include tremors, palpitations, tachycardia, and headache. Rare but serious adverse effects could include paradoxical bronchospasms, cardiovascular effects, and hypokalemia. It is contraindicated in patients with hypersensitivity to salbutamol, and it's used in caution with infants who have hypertension, hyperthyroidism, or are hypokalemic. Concurrent use of beta blocking agents is not advised. Teratogenic risks is also unknown, and salbutamol is considered compatible with breastfeeding when used at therapeutic doses. Next, moving on to phenylephrine. Phenylephrine is a sympathomimetic drug, primarily an alpha 1 adrenergic receptor agonist. It works by stimulating alpha 1 adrenergic receptor in blood vessels, leading to vasoconstriction and increased blood pressure. Common side effects include hypertension, reflex bradycardia, headache, and nausea. If severe adverse effects occur, there may be myocardial infarction, stroke, or cardiac arrhythmias. It is contraindicated in patients with severe hypertension, ventricular tachycardia, or hypersensitivity to phenylephrine. Again, for this drug, the category risk is unknown, and phenylephrine is also considered compatible with breastfeeding when used at therapeutic dosage, but it should be used with caution since it can be expressed in the milk.
So continuing with the pharmacodynamics, we have chlorpheniramine, a antihistamine H1 blocker. It binds to the histamine H1 receptor that blocks the action of endogenous histamine, which subsequently leads to temporary relief of the negative symptoms brought on by histamine. Its adverse effects are drowsiness, headache, fatigue, dry mouth, and double vision. It is contraindicated in patients with hypersensitivity to chlorpheniramine or any component of the formulation. It is under FDA Category B, and small doses, like occasional doses of 2 to 4 milligram of chlorpheniramine, are acceptable during breastfeeding. Next, we have Montelukast, a leukotriene receptor inhibitor that blocks the cis-LT1 receptor to reduce bronchoconstriction in asthma. Its adverse effect is elevation in serum hepatic enzyme. It is contraindicated in patients which have history of hypersensitivity to Montelukast. It is under FDA Category B, and it is still safe to use in breastfeeding mother and with low doses. Next is ceftazidime, which is a third-generation cephalosporin that interferes with bacterial cell wall synthesis and inhibits cross-linking of the peptidoglycan. Its adverse effects are hypersensitivity, like maculopapular rash, urticaria, and pruritus. It is contraindicated in patients with hypersensitivity to penicillin and history of gastrointestinal disease. It is under FDA Category B, and low levels in milk that are not expected to cause adverse effect in breastfed infants. Next, we have amikacin, which is a aminoglycosan that binds to bacterial 30S ribosomal subunit and interferes with mRNA binding and tRNA acceptor sites, interfering with bacterial growth. Its adverse effects are hypersensitivity, neurotoxicity, ototoxicity, nephrotoxicity, and respiratory paralysis. It is contraindicated in patients with renal or hepatic disease and pre-existing hearing loss. It is under FDA Category D, and it is poorly excreted into the breast milk. Next we have is trimethoprim. It is a antimetabolite. It selectively inhibits bacterial dihydrofolic acid reductase, which converts dihydrofolic acid to tetrahydrofolic acid, a step leading to the synthesis of purines and ultimately to DNA. Its adverse effects are megaloblastic anemia, leukopenia, and granulocytopenia. It is contraindicated in patients with hypersensitivity and patients that have megaloblastic anemia due to folate deficiency. It is under FDA Category C. Breastfeeding is not indicated. Next, we have sulmethoxazole. It is under sulfonamides, and it blocks the reduction of dihydrofolate to tetrahydrofolate, the active form of the folic acid, by susceptible organisms. Its adverse effects are nausea, vomiting, anorexia, diarrhea, and hypersensitivity reactions. It is contraindicated in patients with severe renal or hepatic impairment. It is under FDA Category D, and it is used in infants younger than 2 months of age, and it is not recommended.
For the pharmacokinetics of the drugs, first, we have the vincristine. It is poorly absorbed from the GI tract within 15 to 30 minutes. 90% is distributed from the blood into tissue, where it remains tightly bound. Protein binding is 75%. It undergoes hepatic metabolism and excreted in the urine and mainly via bile into feces as unchanged drug and metabolites. Second, we have doxorubicin. Rapidly cleared from the blood after IV administration, it crosses the placenta and enters the breast milk. Volume of distribution is 809 to 1214 liter per meter squared. Plasma protein binding is approximately 75% and rapidly metabolized mainly in the liver by aldoketoreductases. It is excreted in the urine as unchanged drug and metabolites. It can also be excreted in the feces for conventional formulation. Next, we have L-asparaginase. Plasma concentration peaks within 1 to 2 hours and distributed mainly within the intravascular space, approximately 20% in the lymph. Excretion is via urine in small compounds. For paracetamol, it is well absorbed following oral and rectal administration, mainly absorbed in the small intestine with minimal absorption from the stomach. It is widely distributed into most body tissues except fat. It can cross the placenta and enters the breast milk. It is metabolized mainly in the liver into sulfate and glucuronide conjugates, while a small amount is metabolized by CYP2E1 to a minor hydroxylated metabolite and excreted mainly in the urine. For salbutamol, it is readily absorbed from the GIT. For the peak plasma concentration, 25 to 30 minutes via inhalation and less than 2 hours via oral intake. It crosses the placenta and has a plasma protein binding of 10%, metabolized in the liver to an active sulfate conjugate and mainly excreted in the urine and some into the feces. For phenylephrine, it is readily absorbed via oral intake. Bioavailability is approximately 40% oral. Time of peak plasma concentration is 0.75 to 2 hours. Rapid distribution into peripheral tissues with minimal penetration into the brain. Volume of distribution is 200 to 500 liters. Metabolized in the liver via sulfate conjugate and undergoes first pass metabolism in the gut and liver by monoamine oxidase. It is excreted renally as inactive metabolites.
For chlorpheniramine, it is well absorbed from the GI tract after oral administration with peak plasma concentrations occurring within 1 to 4 hours. Its half-life is approximately 20 hours. It has a relatively high volume of distribution, indicating that it is extensively distributed throughout the body. It is metabolized primarily in the liver by the cytochrome P450 enzyme system, primarily by the CYP2D6 and CYP3A4. Chlorpheniramine and its metabolites are primarily eliminated throughout the kidneys, with approximately 60 to 70% of a dose excreted in the urine within 24 hours. For Montelukast, it is rapidly absorbed after oral administration, with peak plasma concentrations occurring within 3 to 4 hours, and its half-life is approximately 2.7 to 5.5 hours in adults. It has a low volume of distribution, indicating that it is mainly distributed in the plasma. It has been determined that Montelukast is highly metabolized and typically solved by the cytochrome P450, 3A4, 2C9, and 2C9. It has been reported that Montelukast and its metabolites are almost exclusively excreted in the bile and into the feces. For ceftazidime, its Cmax and AUC show linear proportionality to the dose over the therapeutic range. In individuals with normal renal function, it is given intravenously every 8 hours for 10 days as either 1 or 2 gram doses and showed no accumulation. It has a volume of distribution of 15 to 20 liters. Its excretion is approximately 80 to 90% of an intramuscular intravenous dose of ceftazidime is excreted and changed by the kidneys over a 24-hour period. For amikacin, it is rapidly absorbed after intramuscular administration. Its rapid absorption occurs from the peritoneum and pleura. Its volume of distribution is 24 liters, and amikacin is also distributed in the bile, sputum, bronchial secretions, interstitial pleura, and synovial fluids. Amikacin structure has been altered to reduce the possible route of enzymatic reactivation, thus reducing bacterial resistance. Many strains of gram-negative organisms resistant to gentamicin and tobramycin have shown to be sensitive to amikacin in vitro. And for excretion, this drug is eliminated by the kidneys. In adults with normal renal function of 94 to 98% of a single IM or IV dose of amikacin is excreted unchanged by glomerular filtration in the kidney within 24 hours. For trimethoprim, steady-state concentrations are achieved after approximately 3 days of repeated administration. It is extensively distributed into various tissues following oral administration, including sputum, middle ear, and bronchial secretions. It undergoes oxidative metabolism to a number of metabolites, the most abundant of which are the demethylated 3' and 4' metabolites. For its excretion, approximately 10 to 20% of ingested trimethoprim dose is excreted, primarily in the liver, while 50 to 60% of trimethoprim is excreted in the urine within 24 hours. For sulfamethoxazole, it is rapidly absorbed following oral administration and has a bioavailability of 85 to 90%. The volume of distribution following a single oral dose was found to be 13 liters. Its metabolism is mediated primarily by arylamine and acetyltransferase enzymes, which are responsible for acetylation of sulfamethoxazole at its N4 position. And for its excretion, 84.5% of a single oral dose is recovered in the urine within 72 hours.
So, moving forward with indications and effects of the drugs discussed above, firstly, we have vincristine or vincristine. Under the indications, we can see that it is considered as one of the treatment plans for young kids with lymphomas, solid tumors, and leukemias, for example, neuroblastoma, Wilms tumor, and rhabdomyosarcoma as well. It is also an important agent in large cell and non-Hodgkin lymphoma. Under the effects, we can see that it basically impedes the development of the cancer cells, which further eventually leads to the destruction of the cancer cells. It also prevents the development of the microtubules in the S phase and also prevents the synthesis of DNA and RNA. The next drug we have doxorubicin. It can be used for breast cancer, Hodgkin's and non-Hodgkin's lymphoma, soft tissue sarcoma, ovarian cancer, non-small cell cancer, and small cell lung cancer, thyroid cancer, Wilms tumor, and neuroblastoma. Under the effects, we can see that this drug basically impairs the topoisomerase 2 function and inhibits the replication and transcription. Then we have L-asparaginase. Uh, Under the indication, we can use this drug for acute lymphoblastic leukemia or ALL and lymphoblastic lymphoma, which is LBL. And for the effects, basically, this drug is an enzyme which catalyzes the conversion of amino acid L-aspargine into aspartic acid and ammonia, wherein the depletion of plasma aspargine would depend on the exogenous source of aspargine for survival. Next, we have paracetamol. So, under the indications, basically this drug is useful in mild to moderate pain, such as headache, myalgia, postpartum pain, and other circumstances in which aspirin is an effective analgesic. And for the effects, this basically relieves mild to moderate pain when an anti-inflammatory effect is not necessary. Then for salbutamol, under the indications, we can use this drug against or in the cases of asthma, COPD, and exercise-induced bronchospasm. Oral albuterol has the potential to delay the preterm labor as well. Under the effects, it causes a symptomatic relief of bronchospasm, wherein it would relax and open up the airways. Then we have phenylephrine. Under the phenylephrine, the indications could be it is one of the decongestants for minor allergic hyperemia and itching of the conjunctival membranes. Localize the lesion in Horner syndrome as well as the mydritic as well. Under the effects, this increases the peripheral arterial resistance and decreases the venous capacitance. So for chlorpheniramine, the indication says that it relieves red, itchy, watery eyes. It can be used in sneezing, itchy nose or throat, and runny nose, which is caused by any allergies as well, and for hay fever as well, and the common cold as well. For effects, this basically binds to the histamine H1 receptor. This blocks the action of the endogenous histamine, which subsequently leads to temporary relief of the negative symptoms brought by the histamine. Then we have montelukast. Under the indications, it can be used for asthma, exercise induced bronchoconstriction, and seasonal allergic rhinitis as well. For effects, given that montelukast is a highly selective leukotriene receptor antagonist that binds with high affinity to the cystinyl leukotriene receptor for the leukotrienes D4 and E4. This agent would inhibit the edema, smooth muscle contraction, and impairment of the normal cellular activity mediated by leukotrienes. Then we have ceftazidime. Under the indications, this is basically treatment of lower respiratory tract infections, skin and skin structure infections, urinary tract infections, bacterial septicemia, bone and joint infections. Then we have under the effect. This is basically bactericidal effect through inhibition of enzymes which are responsible for cell wall synthesis and primarily penicillin binding protein 3, which is PBP3. Next, we have amikacin, and for the indications, this drug is used as a short treatment or short term treatment of serious bacterial infections due to susceptible strains of gram negative bacteria. And for the effects, this drug is basically based on the disruption of normal protein synthesis and production of non functional or toxic peptides. Then we have trimethoprim, and under the indications, we have two parts. Firstly, against urinary tract infection. So, this drug is effective against many strains of bacteria that commonly cause UTIs, which could be E. coli or Staphylococcus saprophyticus. And secondly, for the respiratory tract infections, trimethoprim can be used to treat the respiratory tract infections such as bronchitis and pneumonia, which are caused by susceptible strains of bacteria. And for the effects, we have two subparts in this as well. Firstly, inhibition of the bacterial growth. Trimethoprim inhibits the growth of the bacteria by interfering with the synthesis of folic acid, which is essential for bacterial growth and reproduction. Secondly, it's reduction in inflammation. So, trimethoprim can also help to reduce the inflammation caused by bacterial infections, particularly in the urinary tract. Then lastly, we have sulfamethoxazole. Under the indications, basically a combination of trimethoprim sulfamethoxazole is effective treatment for a wide variety of infections, including the urinary tract infections, prostatitis, and some infections which are caused by Shigella, Salmonella, and non-tuberculous mycobacterium. And for the effect of the same drug, the combination of trimethoprim and sulfamethoxazole is often bactericidal when compared with the bacteriostatic activity of the sulfamethoxazole alone.
Moving on to antimicrobial coverage, let's start with penicillin. Its mechanism of action is to inhibit bacterial cell wall synthesis, and it has activity against the following organisms: Staphylococcus aureus, Streptococcus pyogenes, Streptococcus pneumoniae, Streptococcus viridans, Clostridium, Neisseria gonorrhoeae, and Neisseria meningitidis. Next is ampicillin with a similar mechanism of action, having activity against Streptococcus pyogenes, S. pneumoniae, S. viridans, Listeria, E. coli, Salmonella, Shigella, and Haemophilus influenzae, as well as Proteus mirabilis. Following that is amoxicillin, also with a similar mechanism of action, having activity against Corynebacterium, Clostridium, Listeria, Salmonella, Shigella, Pseudomonas aeruginosa, Helicobacter pylori, Legionella, Neisseria gonorrhoeae, Klebsiella pneumoniae, Enterobacter cloacae, Serratia marcescens, Bacteroides, and Fusobacterium and Prevotella. Next is oxacillin with a similar mechanism of action, having activity against Corynebacterium, Clostridium, Listeria, Salmonella shigella, Pseudomonas aeruginosa, Moraxella catarrhalis, Helicobacter pylori, Klebsiella pneumoniae, Proteus mirabilis, Enterobacter cloacae, Serratia marcescens, Bacteroides, and Fusobacterium and Prevotella. Lastly, we have vancomycin with a mechanism of action that involves binding to D-alanine, a terminal component of peptidoglycan precursors, preventing cell wall synthesis and causing bacterial death. It has activity against Staphylococcus aureus, Streptococcus pyogenes, Streptococcus viridans, Corynebacterium, and Clostridium.
Cephalexin, cefuroxime, ceftriaxone, ceftazidime, and cefepime are all cephalosporins. Cephalosporins work in a similar way by binding to penicillin-binding proteins and inhibiting peptidoglycan synthesis, which is essential for bacterial cell formation. This leads to cell death in susceptible bacteria. Trimethoprim sulfamethoxazole or TMP-SMX works by inhibiting two bacterial folate synthesis pathways. Trimethoprim inhibits dihydrofolate reductase, while sulfamethoxazole competitively inhibits paraaminobenzoic acid utilization. Folate is essential for bacterial growth, and its depletion disrupts bacterial DNA function and leads to cell death. Ciprofloxacin and levofloxacin are fluoroquinolones. They work by inhibiting bacterial DNA gyrase and topoisomerase 4 enzymes, which are essential for DNA replication and repair. This disrupts bacterial DNA function and leads to cell death. Doxycycline is a tetracycline, so it works by binding to the 50S ribosomal subunit of bacteria, inhibiting protein synthesis. This prevents essential protein production and leads to bacterial death. Erythromycin and azithromycin are macrolides. They also work by binding to the 50S ribosomal subunit of bacteria, inhibiting protein synthesis. This prevents essential protein production and leads to bacterial death. Chloramphenicol works by binding to the 50S ribosomal subunit of bacteria, and also inhibiting protein synthesis. This prevents essential protein production and leads to bacterial death. Clindamycin works by binding to the 50S ribosomal subunit of bacteria, inhibiting protein synthesis. This prevents essential protein production and leads to bacterial death. Linezolid works by binding to the 23S ribosomal subunit of bacteria, also inhibiting protein synthesis. This prevents essential protein production and leads to bacterial death. For Staphylococcus aureus, cefalexin, cefuroxime, ceftriaxone, TMP-SMX, ciprofloxacin, levofloxacin, doxycycline, erythromycin, azithromycin, chloramphenicol, clindamycin, and linezolid all have coverage. For Streptococcus pyogenes, cefalexin, cefuroxime, ceftriaxone, TMP-SMX, levofloxacin, doxycycline, erythromycin, azithromycin, chloramphenicol, clindamycin, and linezolid all have coverage. For Streptococcus pneumoniae, cefuroxime, ceftriaxone, TMP-SMX, ciprofloxacin, levofloxacin, doxycycline, erythromycin, azithromycin, chloramphenicol, and linezolid all have coverage. For Streptococcus viridans, cefalexin, cefuroxime, ceftriaxone, TMP-SMX, erythromycin, and azithromycin all have coverage. Levofloxacin is shown to have diminished susceptibility, and doxycycline is listed as an alternative for those who cannot tolerate penicillin. For Corynebacterium, levofloxacin, doxycycline, erythromycin, azithromycin, and clindamycin all have coverage. For Clostridium, clindamycin and linezolid have coverage. Cefuroxime also has coverage except for Clostridium difficile. Ceftriaxone has coverage, but most strains of Clostridium difficile are resistant. Levofloxacin has limited activity. Doxycycline is not used therapeutically but can prevent the virulence factors of toxigenic Clostridium difficile. Clostridium welchi is resistant to erythromycin, and azithromycin is not used for these microorganisms. For Listeria, ceftazidime, levofloxacin, erythromycin, azithromycin, and linezolid all have coverage. Doxycycline can also be used when penicillin is contraindicated. For Escherichia coli, cefalexin, cefuroxime, ceftriaxone, TMP-SMX, ciprofloxacin, levofloxacin, doxycycline, and azithromycin all have coverage. Escherichia coli is resistant to erythromycin. For Salmonella, cefuroxime, ceftriaxone, levofloxacin, doxycycline, azithromycin, and chloramphenicol have coverage. Salmonella is resistant to erythromycin. For Shigella, cefuroxime, ceftriaxone, ciprofloxacin, levofloxacin, doxycycline, azithromycin, and erythromycin have coverage. For Pseudomonas aeruginosa, ceftriaxone, ceftazidime, cefepime, ciprofloxacin, and levofloxacin have coverage. This bacteria develops some resistance to doxycycline and resistant to erythromycin and azithromycin. For Moraxella cataralis, cefuroxime, ceftriaxone, ceftazidime, TMP-SMX, levofloxacin, doxycycline, erythromycin, azithromycin, and clindamycin have coverage. For Helicobacter pylori, cefuroxime, levofloxacin, and doxycycline have coverage. Helicobacter pylori is resistant to erythromycin and azithromycin. For Legionella pneumophila, ciprofloxacin, levofloxacin, erythromycin, and azithromycin have coverage. For cefuroxime, this needs to be given with an agent active against Legionella. Doxycycline is an alternative therapy for bacteria. For Neisseria gonorrhea, cefuroxime, ceftriaxone, ciprofloxacin, doxycycline, and erythromycin have coverage. Levofloxacin is recommended by the CDC for uncomplicated gonorrhea. Azithromycin also has coverage but is not recommended. For Neisseria meningitidis, cefuroxime, ceftriaxone, ciprofloxacin, levofloxacin, doxycycline, azithromycin, and chloramphenicol have coverage. Neisseria meningitidis is resistant to erythromycin. For Haemophilus influenzae, cefuroxime, ceftriaxone, TMP-SMX, ciprofloxacin, erythromycin, azithromycin, chloramphenicol, and clindamycin have coverage. Resistance is reported to levofloxacin and low resistance to doxycycline. For Klebsiella pneumoniae, cephalexin, cefuroxime, ceftriaxone, TMP-SMX, ciprofloxacin, levofloxacin, doxycycline, erythromycin, and azithromycin have coverage. For Proteus mirabilis, cephalexin, cefuroxime, ceftriaxone, ciprofloxacin, levofloxacin, erythromycin, and azithromycin have coverage. Resistance is reported to doxycycline. For Enterobacter cloaceae, ceftriaxone, cefepime, ciprofloxacin, levofloxacin, doxycycline, and azithromycin have coverage. This bacteria is resistant to erythromycin. For Serratia marcescens, cefuroxime, ceftriaxone, cefepime, ciprofloxacin, levofloxacin, and azithromycin have coverage. Serratia marcescens is intrinsically resistant to doxycycline. Also, is resistant to erythromycin. For Bacteroides, cefuroxime is used synergistic with penicillin or carbenicillin, but is mostly resistant. Ceftriaxone, ceftazidime, levofloxacin, doxycycline, erythromycin, azithromycin, chloramphenicol, and clindamycin have coverage. For Fusobacterium and Prevotella, cefuroxime, ceftriaxone, levofloxacin, doxycycline, erythromycin, azithromycin, and clindamycin have coverage. And that ends our group presentation for the Pharmacology Workbook Exercise 5 about antibacterial agents. Thank you very much.